Good morning and welcome to this WellSteps webinar, Wellness and High Cost Employee, presented by Dr. Stephen Aldana. It is our pleasure to welcome you on this webinar today. As we always do, I would like to just remind you that there are many of you, about 750 people have registered for this webinar, and so all phones have been muted to prevent background noise. However, you will be able to interact and ask questions at any time by using the chat function on your GoToWebinar control panel, which should appear on the right side of your computer screen. We are recording this webinar. It will be available within about an hour after the end of the webinar. We encourage you to watch it again if you'd like, or to share it with any of your colleagues who might have missed the webinar today. It is my distinct pleasure to introduce Dr. Stephen Aldana. He almost needs no introduction. Many of you have met him and have heard him speak as he's crisscrossed the country. He's one of the most knowledgeable people in this area that I know, and he's been really excited to dig into the research I know to prepare this webinar for you, Wellness and the High Cost Employee. He's learned a lot. In fact, he's learned that disease management dates back to 1932, and I'll leave that one hanging. We're so excited he gets to go and represent WellSteps down in Brazil during the coming week, and we don't know whether or not he's going to go to any World Cup soccer matches, but he's certainly going to have a presence down there. It is without further ado that I introduce my business partner, Dr. Stephen Aldana.
Thanks, Troy. Let me remind everybody that you can use your control panel, ask questions anytime you want. We've got a team back there that's going through all the questions. It makes these webinars a lot more interactive, so feel free to ask the questions, complaints, anything you want. Let's have an open and free discussion about all of this. The reason we're here is there was an account that we worked with not long ago, and they decided to do all of their wellness under the umbrella of disease management. In other words, they weren't going to do any wellness. They looked at some wellness vendors, they looked at on-site clinics, they looked at a lot of different things, and they said, you know, we're just gonna use our carrier's disease management program, and that's going to solve our poor employee health. In fact, what their words were, we're going to manage our population with disease management. And I was pretty surprised by that. That might have been an approach we'd have seen 5 or 10 years ago, but it's pretty uncommon for us to see that solution. It bothered me because there's an awful lot of tools in the tool bag for employers to use. By the way, this is a very large and sophisticated well, maybe not sophisticated, a very large organization that was working with some consultants, and quite frankly, I was pretty surprised that they missed all of the tools that are in the tool bag to help them control costs. Now, we're talking mainly about healthcare costs today, but last night at 11 o'clock, I got back from Richmond, Virginia, and I'm out in the Rocky Mountains. I did a large broker producer slash HR benefits meeting. They took some surveys of the group, and the employer HR people were stating that the number one reason they want to do wellness is to improve employee health and productivity. The number one reason for wellness. When we ask the CFOs or the leadership, upper senior leadership, it's obviously a different answer. They want to do this to control healthcare costs. So today we're focusing on the healthcare cost of this equation. And with other companies saying, well, we're going to do just disease management, I wanted to just share with you, one, what does the literature really say about the tools that we have in our toolbox to solve this cost problem? How does wellness integrate in with this? What are the roles? What do we know from both the literature and from the real world? And I want to tie this all together in some things that any employer can do to really get a better handle on the cost, particularly the high cost employees. And we're talking about high cost. Here's the data from Kaiser from 2013. In the US, it's $9,700 per person per year. That's the cost for healthcare in the United States last year. $9,700. Now that's all Americans, not just the employed Americans or those with insurance. It's Medicare, it's Medicaid, it's young, it's old, it's everybody. That's the actual data as they have tracked it, and theirs is the best tracking we have access to, and they project in yellow that by 2018 it'll be $13,100 per person per year. So in 4 more years, we expect that number to reach about 13,000. And this year in particular, a little bit lower increases than we expected. But the reason that a lot of us are here today is this isn't going to change. Now, all the benefits of Affordable Care Act are really focused on inclusion and providing access to healthcare, but there's very little in there to really have any meaningful impact on cost. So what happens to you and I? Well, over the last few years, since 1999, this is what inflation has done for us and our employees. So over the last, looks like it's about 13 years, just the cost of inflation has increased goods and services by 38%. So things cost 38% more than they did 13 years ago. That's just inflation. Your employees, my employees, we get increases in our salaries. Well, if you want to look at increasing in workers' earnings, that's the rate at which workers' earnings have increased, and they're in the same time period. So put another way, 13 years ago, or compared to 13 years ago, the average person is making 47% more dollars than they were 13 years ago. Well, that's slightly ahead of inflation, which is good. But then we asked the question, what's been the percentage increase in the cost of healthcare during the same time period? And there's where we have the light blue line. So this is really evidence as to why we have 750 people on a Friday morning getting together on a webinar to talk about healthcare costs and high cost employees and wellness, is because of that data right there. It goes one step further. In the last 13 years, the cost of healthcare is 172% higher than it was 13 years ago. The amount that employees contribute to that cost is the gray line. So what this is over that same time period, we've all got a slight increase in our salaries, a little bit more than inflation. Healthcare costs have almost doubled, and the amount that we as employees contribute to that cost has gone up by 172%. So even though you're making more money, you're taking home less money because a larger and larger portion is going to pay for the cost of the care. And it is that difference between what we make and what we're paying that is explaining a lot of the pressure that employers are feeling. Employers would love to be able to pay more and more of the cost, but many can't, so they shift the cost to employees. So what are employees paying today? Well, here's the Kaiser data for insured employees. Single family is a single employee is $5,800. The family is $16,000. So this is the 2013 data. So for employed adults who have insurance, this is what the number is, and this is what the number looks like. So in our discussions today, some of you know how much your companies are spending for healthcare, and some of you don't. So just to give you a ballpark idea, a very rough idea, if we take this number 5,800, that's for a single employee, and that's the average in the United States for what it costs. And by the way, the $1,000 is the worker contribution, and $5,000 is the employer. So the employers are paying 5 times more of the cost, even though they've been shifting. For a typical company, for example, of 50, well, 50 times $5,884, that's almost $300,000. That's the cost for that company to ensure, to provide care for 50,000 employees. Now that's the employer contribution and the employee contribution. That's independent of co-pays, deductibles, things like that. It's usually just premiums. So for a company of 500, it's almost $3 million. For a company of 5,000, it's almost $30 million. So I want you to get an idea of the dollar amounts that we're talking about. You can take your company, if you don't know what it is, you can take your number of employees times, approximately 6,000 or whatever your numbers are, to give you an idea about what that cost bucket is. How much does this cost your organization? Because this is what we're going to whittle away at today, that cost. 13 years ago, it was smaller, and then a year or two later, it got bigger, and then it gets bigger, and it continues to get bigger every single year. It's gone up 172% in the last 13 years. So now really is the question as to why. What's making this expense so much bigger year over year over year? So when we look at the drivers, what's really driving this? If we're going to talk about wellness, we're going to talk about how to bend this high cost trend, then we need to know, well, what are the drivers? Because if we can start to adjust or tweak the drivers of the cost, then we can start to actually see some changes in the total cost. Well, the drivers, one, unhealthy behaviors. And everybody knows the obesity rates, the diabetes rates are big drivers. What we don't fully understand is how much of that impacts employers, because once you turn 65, the employers, or most of them, don't offer retirement insurance anyway. You become a burden of the state. Medicare starts to pitch in that cost. It's not an employer cost per se, but unhealthy behaviors before 65 and those diseases, yeah, that's a piece there. There's also the salaries and the drug costs that are available. I'm always reminded of the Medicare Part D, which is prescription medication insurance for Medicare patients. Having the discussion with my mom, should I pay this premium every month I need a few medications? And I says, no, Mom, I kind of looked at the numbers. To be honest with you, let's not pay the premium. Let's not join Medicare Part D. If you need medications, we'll order them from Canada. Why? Because Canada is allowed to negotiate with the big pharmaceutical companies for lower prices. So we can get your medication for about a third the price, and we'll get it from Canada. That's how we avoid the drug cost, at least in our little world here. But salaries are very high. And then there's the expensive technologies. Now that MRI is a multi-million-dollar piece of equipment, and the doctors are going to use it when they need it. Well, that's a big cost. And the technologies are good, but they're horribly, horribly expensive. Well, they're so expensive, Congress said, we're going to put a tax on the medical device manufacturers. We think they're making too much money. We're going to tax them as part of Obamacare. There's some excess there for sure. And the biggest, richest companies in most of our communities today are our healthcare providers and those that support those providers. So there's this business of fragmented care. My primary care doc and my specialists don't talk, and they're not really visiting with the OBGYN, or there's this care fragmented. We're not really organized and keeping track of people. There's the lack of cost consideration. That's me with my insurance card, and I go to the doctor and I plunk my card on the counter. And to be honest with you, I don't even know what the cost is, because my perception is I have insurance. It's not my money. I really don't care. So it's the lack of transparency or the lack of shopping is driving this cost higher and higher. Fee for service is doctors who are getting paid to either put something in you or take something out of you. They get paid, they make their fee by doing something. Just talking with you is not doing something under the current model. So the incentives for physicians to make money is to do stuff. So there is obviously a conflict of interest. When I get the more money I make is based on the number of procedures that I do, in the back of my mind, I'm going to go with more versus less if I have an option. That drives cost. There's the high administrative costs, and that has to do with claims processing, our insurance companies. It's the cost of getting this stuff paid. And as you all know, it's a very complicated, messed up thing. End of life care is horribly expensive. And then there's this business of provider consolidation, which means hospitals are buying doctors and doctors are buying hospitals, and specialty clinics are expanding, and we're getting these monopolistic healthcare provider organizations throughout communities around the United States. And as they do, they are much more able to control cost. Now, these are the ones that have come up with all the big think tanks and all the big groups evaluating what's the problem. Well, your company cost is being driven by these factors. So when we look at these and we go, okay, I see why my healthcare costs are so high. Which of these can I really influence? I mean, which of these can I really do anything about? You know, take something like end of life care. if it's a personal family member, you've got to have that discussion. Do we want to work hard to do everything possible to save this person? If cancer sets in and it's a very aggressive cancer, are we going to go through the surgery and then the radiation and then months and months of chemotherapy with really no for sure knowledge what's going to? Those decisions are tough. They're very tough. What can a company do about that? Boy, those are tough ones. We have hospice, we have other ways, but you can see this is complicated because we don't have the ability to tweak a lot of these factors. So what are the strategies that employers use to start to control healthcare costs? Well, here's the list, and this is just a rough list. There's a lot of other smaller things that are out there, but what can an employer do to make this change? I've listed everything that are the big ones. And I know some of you may be very disappointed when I list something like, we'll stop offering a healthcare benefit. One solution to your cost problem is don't provide insurance for your employees. Oh, that's crazy. We could never, it's an option. It is an option. Everything's on the table. You and your advisors and your consultants and your employees and leadership will have to decide which of these you want to use to try to make a difference. So you can stop insuring people. You can cost shift, which has been going on for a lot of years, which I've already demonstrated. You could try to save money by changing carriers. Well, Blue Cross has been beaten up with our price, so we're going to go to Anthem, and we're not really happy with the way they do our service, so we're going to go to Cigna, but Cigna is really complicated, so we're going to go back to Aetna, and then we're going to jump over to United, and then we're going to go. You can play that game, and you might get a small little savings in year one, but it's tough to play that. You can negotiate rates. You get your broker and your consultant, and you can beat each other up over rates, and you can nitpick, and we want this and we want that, and you can try to whittle away with rates. You can self-insure. You can do your own internal insurance for your employees, and there's some interesting things going on in that world. You can offer high deductible plans where the amount of out-of-pocket money for each employee goes way up. You can provide an on-site clinic to provide medical services at the work location. You can do disease management to manage the chronic conditions that are there. And you can do wellness. So these are the strategies that are in the toolbox. This is what we have at our disposal to work with. What do we know about each one? What does the evidence say about each of these? How do they work together? Better yet, of the companies that have really demonstrated very strong control over their healthcare cost spend, what are they doing? Which of these tools are they implementing, and how do they take care of that? So let's just briefly go through these real quickly to talk about them because they're connected. Self-insurance affects high administrative costs. In fact, you can eliminate a big portion of that. You still have to have someone process your claims, but there's no insurance carrier in that model. You can do something like a high deductible plan, which reduces the demand for services for high cost and fee for service. You can do on-site clinics, which is a way to get cheaper physicians and drug costs, and you can avoid provider consolidation. And there's the disease management piece that's connected. And then there's wellness, which affects an awful lot of these. So you can see that they're definitely connected. Let's take a look at each one and kind of see how they work. So let's just stop offering the benefit. We're going to get out of the healthcare business altogether. This is an interesting one. This one scares people. In May, I was in Montreal, and there was a group of 700 employers, and they brought me in to talk about wellness and the impact of wellness. So why would 700 employers in Canada with socialized medicine, in other words, they don't pay for healthcare as an employer, what are they interested in? They've already done this. Technically, they didn't stop providing healthcare benefits. They never did because it's a socialized system. There's a public option. Everybody has it. They don't have employer-based healthcare. On Monday, I've got to go to Florianopolis, Brazil, to talk to 600 industrial groups down there who want to know about wellness. They too don't offer benefits for healthcare for their employees. Well, those are socialized systems with a public model, and they do wellness for productivity, morale, retention, recruitment, absenteeism. They do it for all the other reasons besides healthcare costs. But here in the US, Trader Joe's has gotten rid of all their part-time employees off their plan. Home Depot, every employee who's part-time at Home Depot no longer has Home Depot insurance. They're on their own. Trader Joe's gives everybody $500, and they said, we're going to give you a stipend. You go out into the exchange. We hope you find money. 2 days ago, the CEO of Starbucks was in the Wall Street Journal, and he talks about their movement out of the benefits business for all of their part-timers. And again, in the US right now, it's only been part-timers. It's been a net win for them. In other words, it's cheaper for the company to pay a penalty and push their employees into the exchanges and have the employees get a supplement from the federal government to help pay the cost of their premium. It's cheaper for the employee saves money, they get a better plan, and the employer saves money by completely getting out of the benefits business. Now, that's a pretty radical change that's going on here, and I understand that scares a lot of people, and there's reasons for and against that. But I'll give you one small example, and that's WellSteps. WellSteps has 22 employees. And how do we do this? So we're just a small little guppy in this large pool of businesses. Well, our employees in all their glory, and just so you can see their pictures here, we give them a health reimbursement account, an HRA. So we deposit money into their accounts every month, enough to cover the premium for most of them, and then we leave it up to them to find the care that they want to find. So we don't provide insurance for our employees. We provide a set amount of money for them to go find their own. Now, that's exactly what Home Depot and Trader Joe's and Starbucks has done. We're small enough that we don't have to pay the penalty. So it's even a bigger boon for us because there's no federal penalty yet till we get large enough. But it's not unheard of. And we have a young workforce that works well for us. It doesn't work well for everybody. But what we did do is we locked the cost. So how does WellSteps handle the high-cost employee? The high-cost employee gets a stipend to pay for part of their cost, and then they're on their own for insurance. We have locked our risk. Our risk control for employee health care costs is fixed, completely fixed. I'm not worried about rates next year or the rates after that or where it's all going because our rate is locked in and it's fixed. Now, that's one option. Cost shifting is the most common option employers are doing. So you can send employees to the working spouse's plan. Now, I know that sounds a little strange, but there are strategies. There are groups that teach employers how to do this. Your employees are married. Many of those married spouses are working at jobs that have insurance. So there are strategies in place to where we can force you, we can motivate you, we can incentivize you to leave our company's insurance plan and go to your spouse's. So it's basically passing the buck or cost shifting to somebody else's plan. You can charge more for employees who have spouses and dependents. You know, that's kind of what we do. A family plan costs more than an individual plan. That's cost shifting. You can charge more for smokers. That's cost shifting. You can charge more for poor health behaviors or poor health risks or poor health outcomes. That's cost shifting. You can reverse cost shifting and say, if you are healthy and you're making the right attempts to be healthy and your risks look good, you pay less. So you can reverse that also. But cost shifting is one of the biggest ones that it's the one most of us do. And this chart that I showed earlier, remember, the blue line on the very bottom was inflation. The green line, that's your increase in salaries, across time increase in pay. The blue line at the top, that's the cost increase of healthcare. And the gray line is the cost increase of the employer's contribution. Excuse me, the employee, the workers. This is cost shifting. Oh, healthcare costs are going up, or premiums are going up again, they're going up more. Okay, employee, you're going to be paying just as much to keep up with that cost. Employees are carrying the larger and larger burden of that cost. Well, it's a tool in your toolbox. You can shift the cost. At some point in time, employees start to push back and say, it's too much. We don't, it's too hard. I'm not making enough money. I can't make ends meet. It's too burdensome. That's one of the pushbacks that comes from that. You can change carriers. You can negotiate rates. I like to liken this unto this me versus you, carrier versus carrier, broker versus broker. It's a boxing match, man. It's just, we're going to beat each other up until somebody cries uncle, and then I'm going to go find someone else to beat up. And we go around and around and around, and then we can maybe negotiate rates, and we can try to beat each other up. Eventually, this becomes a dead end. And yet, this is the most common approach to solving this problem of healthcare costs, is to do business as usual, change carriers, move around, negotiate rates, try to beat each other up on price. It probably can trim off 0.5% or some bucks, or maybe 1% one year, but it comes back to you. And it's just this churn rate. It doesn't solve the problem long term. What about self-insure? What do we know about that one? Well, it's pretty popular. In small employers, 0 to 200, 16% of those employers are now self-insured. 60% of the less than 1,000 size, 58%, they're self-insured. When you get bigger, the more likely the companies are to be self-insured. Why? Because there's a savings to be had when you self-insure. If we look at the data, we can look at the Kaiser data, we can look at Medicare, Medicaid data that's been published, some of the research reports that have been published. When you self-insure, you can save about 4 to 7% of that annual spend per year. In other words, that's 4 to 7% that would usually go to a carrier or some third-party insurance carrier that you're now taking the risk on yourself. But, and I'm not going to get into this in great depth, your self-insured covers the bulk of your costs, but you also have to have what's called reinsurance or stop loss for the high-cost people. That's a premium, and that's involved. I just spoke with a group for Cigna last week. They're really big into the self-insure piece, and they can self-insure groups down to like 10, which takes some pretty amazing actuarial work to do that. But they can self-insure groups as small as 10 employers, which opens it up to a lot of people. There's some savings here when you self-insure. High deductible plans, holy cow, these are the big ones. Now, by definition, a high deductible plan is increasing significantly the amount of out-of-pocket that an employee pays for first dollar coverage. That's a lot of technical talk for when you go to the doctor and you get a bill, you're responsible for the first several thousand out of your pocket. Insurance isn't going to touch that cost until you've paid a larger portion up front, a high deductible piece. So here's the graph that I showed you earlier. This is the Kaiser Permanente's results on the annual premium costs for employed adults. For singles, it's $5,800. For a family, it's $16 grand. Okay, that's all plans. When you pull out the groups that are high deductible plans, that's what it looks like. So you get 16 down to 15, 58 down to 53. There's approximately a 7% reduction in the cost when you use high deductible plans. And the high deductible plans, they're here to stay. Here's the most recent data. 2006 to 2012, when you've got a $1,000 deductible versus a $2,000 deductible, the prevalence of those benefits plans, they're going up. This is all employed adults. So right now, the prevalence is going way up. 34% of employed adults have a deductible of a greater than $1,000. Another 14% have a deductible greater than $2,000. Steve Aldana and his little family used to have a $10,000 deductible, 10 grand. First 10 grand every year comes out of my pocket. Holy cow. Well, my premiums have been pretty small, $300, $340. So that's for 4 of us. I got this letter in the mail just like a year ago. Hey, Mr. Aldana, this is your insurance company. We just calling to let you know that we lowered your deductible from $10,000 to $7,000. And I'm like, what? You can't do that because you're going to increase my premium dollars. Well, the Affordable Care Act says you insurance companies can only make so much money. They were making too much money. To make less, to get their ratios correct, they lowered my deductible from 10 to 7 at no change to my premium. That was very unusual. If we look across the studies, the published studies, and all the references for these studies are included at the end of this presentation, high deductible plans can save between 5 and 14% per year. Well, that's a pretty big bite out of that pie. You've got your high cost employees, the high cost of healthcare. We've got about 4, 5, 6% can come out of self-insurance. Here's another 5 to 14% can come out of shifting to a high deductible plan. There are some dollars to be saved. And my crystal ball says high deductible plans are here to stay. And they're going to become increasingly more popular as the cost continues to go up. Because now that I have a high deductible plan, I'm much, much more careful as a user of my healthcare services. I'm very careful. Not only that, but I've learned a few skills along the way. I can put in stitches. I can take out stitches. I can reset dislocated elbow. I'm just kidding. I don't do all those kinds. I'm not kidding about the take out stitches though. They're pretty easy to take out. I start to get informed. I start to learn to do some things myself because now I know that if I don't, it comes out of my pocket. So let's shift on to the last couple here, and we'll get tying this all together with wellness. Yesterday, I was in Richmond, Virginia, and I heard a group present from Chenworth. Chenworth is an employer. They have 2 locations, 1,200. They have an on-site clinic. The on-site clinics are pretty impressive. Employees love to have an on-site clinic. And they went to great lengths to make sure that employee privacy is maintained. So they have a separate phone line. They have a separate texting message. They have a separate, well, the location is on site, but they've separated themselves physically and digitally from the company so that there's, they've got windows inside the clinic. They're opaque. You can't see who's in there. You can't see who's sitting in there. They've gone to great lengths to make this thing private. When we look at the reviews of the literature of on-site clinics, whether or not they save healthcare dollars, we know they may improve productivity, but the data isn't very supportive on healthcare cost savings. Now, that was a review by Bruce, I can't remember Bruce's last name, in the Journal of Occupational Environmental Medicine, 2012, where they looked at all the published studies on on-site clinics. So the healthcare cost piece is not clear on the saving side. But from a morale perspective, this group that I met yesterday, the employees love being able to go to this clinic. Now, the CEO and the leadership have opened up the gates. You don't even have to have insurance from their company to use the clinic. Your spouse can use the clinic and they're not even part of their plan. You can bring your kids in to be using this clinic. They make it available to every single employee on site, set an appointment, off you go. They're seeing about 10 patients a day. They love it. All right, let's say it's not saving healthcare costs. From just a purely employee morale perspective, this tells employees, we care about you. You're important. We want you here. We want you engaged. This is a service we provide to you. As an employee, I all of a sudden am going to provide better customer service. I'm going to be more attuned to what I do at work. I'm more committed. I am more connected to my employer than ever because my employer is connected to me. They care. Now, it's tough to put a dollar value on that, but I can tell you from experience, when you provide services that your employees value as a benefit or as an expression of love or caring or we're family, it has a big impact. It impacts every aspect of that employee's life. And that's who you want working for you. So and I don't have any data to back this up. I got no science. I got no hardcore actuarial studies on morale. From a business owner and from a common sense perspective, that's a huge winner right there. Now, it doesn't change your healthcare costs, but it affects every other piece of your organization. The disease management piece, this is where the high cost comes in, because the 80-20 principle says 20% of the employees are responsible for 80% of the cost. What's that number really mean for you? Well, remember, 20% of your employees use 80% of the healthcare services that your company's paying for. Here's what your company's paying for those services. 80% of that number is being used by 20% of your employees. So here's the way this works. The board gets together and they're looking at the balance sheet. They're going over the financials and they're looking really carefully at these numbers. And they're thinking to myself, holy cow, look at that healthcare dollar piece. That healthcare line is huge. We got to do something about that. We're spending a ton of money on those high cost people. We've got to respond to that group. That's where we're bleeding, because that number's really big. That's a big number and we got to get it down. So our task is to push that number down somehow. So we do disease management. So I've got an employee population, and on average, I've got about 20% of those people with some form of disease. They're using 80% of your dollars. Holy cow, how do we stop this? How do we stem the flow? Well, that's where 20% of your employees are. Another 5% typically have some kind of urgent care needs, and that's a cost during the year. Another 60% have elevated health risks, high blood cholesterol, high blood pressure, high blood glucose. And then there's this weird group, this 15% of the group that eats healthy and they don't smoke, they're exercising regularly. I like to joke, they don't need no stinking wellness program. They don't. They're already doing everything that they need to do. So we can try to say, all right, here's the high risk people. Let's take a close look, because if we can focus on that group and try to use predictive modeling, we can determine which of those people are going to become high cost. We can try to intervene with what? With exercise, nutrition, physical activity, medication. Yeah, because the flow goes like this. The well eventually migrate and become those with elevated health risks. We gain weight. Everybody at every company on average is gaining some weight over time. We're increasing our risk. We go from a well, younger, healthy population to increased risk. We may need urgent cares. Eventually, we develop a chronic disease. So we do disease management with this top piece. Maybe it's called condition management, where we talk about compliant support, and taking medications and try not to get worse and try to avoid other diseases. And herein lies the problem. This high cost group, these employees who have the most money being spent, have a turnover rate of 59%, which means when you look at that balance sheet and you see those high cost cases and those employees who are high cost, in 12 months, 59% of those people will be replaced with 59% new. Where do they come from? Well, they come from the well. There are people who migrate through. So just when you think you're targeting this high cost group, we get Dr. D. Eddington, who retired from the University of Michigan last year. He's been always keen on saying, keep the well well. Stop them from migrating to a high cost, high disease state, and you'll save money. He says it's almost too late to start to throw money once they're in this category, because cost is extremely expensive. So what do we know about these? What do they work? Well, there's 317 studies that have been published on these. Good studies, some clinical trials in there, some not so good, but reviews of the entire literature, and there's a whole bunch of those. Ron Getzel's done some of those. It's been around a long time, and there's a lot of data out there. My favorite of all the studies that have been done was the Centers for Medicare and Medicaid pilot study. They took 34 disease management vendors. They spent almost $500 million, $360 million in the first one. So they spent a whole bunch of money, and they said, let's take 34 of the best disease management providers in the country who do lots of different things and multiple format interventions, and they looked at 30,000 patients. Now, the reason I like this is how it is in the real world. If you go out and hire someone to help with disease management, you're going to get a vendor who's going to come in and they're going to do what they do. Great. This study was able to look at them over a long period of time and ask some pretty tough questions. Now, nobody starved and these vendors didn't lose money. They got $500 million to pull this off. But here's what they found, and this is a summary of all of them. It does improve the process of care and disease control. So it helps people navigate the system and learn to get your hemoglobin A1C tested and stay on your medication, and helps them maybe not get worse. The results from health, cost, and quality of life are mixed. We have some studies that say yes and some that say no. There's some limited support for its effect on health outcomes. However, the Medicare-Medicaid study found that the programs did not reduce hospital administrations or emergency room visits. There was no demonstrable savings in Medicare expenditures from this study. So the savings from disease management they're tenuous. I've got some applications for the C. Everett Koop Award on my desk right now that we're reviewing. I'm part of the C. Everett Koop board. There's a couple in there that have had great results from disease management. And for every one of those, I got 3 or 4 that they didn't find anything. So the jury is still out on this as far as I'm concerned. If there is an effect, it's more on improving health and disease process than it is on controlling the cost. So employee-related expenses are obviously impacted by chronic disease. Chronic disease is preceded by elevated health risks and unhealthy behaviors. The way that Dr. Adams and I like to describe this is this river right here. Chronic disease is at the bottom of the waterfall. That's where bad things are happening. Upstream is where people have poor behaviors and elevated health risks. And it's these that really determine which diseases we get and the associated cost. This is the model. So what we see, like this group that I started off with, is companies throwing a whole bunch of money at disease management when in fact it might be a little late. The results are not ideal. And if you could go upstream and prevent the behaviors and elevated health risks in the first place, then we have a much larger impact on the cost. We're saying go upstream. The coaching literature that Dr. Adams reported last month does exactly the same thing. And this is where we get to this idea of population health management. We don't want to just help with the people with disease. We want to talk about everybody. So I like to ask the question, who needs help adopting and maintaining healthy behaviors? Whether they have disease or not, whether they're well, where are they at? Who in this organization can we work with to keep them from ever going over the falls? Or even if they've gone over the falls, help them to reverse or manage their condition. Well, who needs help adopting, maintaining healthy behaviors? It's 100% of every employee. So when we look at the drivers of cost and the strategies, wellness touches and ticks off an awful lot of the boxes. It helps with high admin costs because if you're not using the system, there are no admin costs. Fee for service is not an issue if you don't need service. Expensive technologies are not needed if you don't have the disease. You don't need medications if you're well. You don't care about the physician's salary because you're not seeing a physician. And wellness is the one that impacts the unhealthy behavior. So it's the one that has, in my opinion, the most consistent and best data backing it up compared to disease management, where we got way more data than supportive data than they have. And the studies are bigger and they're better designed. We got population health management, which is the solution. And what it looks like from an engagement model is, well, don't do anything. Traditional wellness kinds of programs, comprehensive wellness programs, and the champion. And I'm not going to say just wellness. I'm going to say groups that do population health management in a traditional fashion, maybe in a comprehensive or in a champion fashion. And let me just explain a little more. Here's kind of what the numbers look like. Small employers, 85% of them aren't doing anything. 11% have traditional programs, 3% comprehensive, and about 1% are these champion companies that really pull out all the stops and as many tools as they can. In larger employers, not very many doing nothing. They can't afford to do nothing. There's a 60% doing some effort in the wellness world, 15% doing comprehensive, and then we've got this group 5% that I call the champion companies that knock it out of the park. And what do? Well, here's the do nothing group. Well, you wait for sickness. We're just going to wait for sickness. Our employee health is really none of our business. This is just a benefit we provide. And most companies take this approach. And we're just going to try to redesign our benefits. So all we're going to do is maybe start shifting cost, and we're going to have a high deductible plan. We'll talk about self-insurance, but that's the most we're going. We're not going to get into it any more than that because it's just not our business. The traditional engagement, yeah, we got a health risk appraisal, and we got an on-site screening that we can do some screenings. We've got a web portal and a nurse hotline. This is kind of what we hear from a lot of companies. Most all the carriers, insurance companies, that's kind of the services they provide. The comprehensive engagement, a little deeper. We've got a wellness committee on site. We encourage low risk maintenance. We've got coaching probably plugged in somewhere. We've got some measurement and evaluation. We have some senior leadership engagement, but not what it should be. Remember, this is the comprehensive one. And then there's the champion one, where they are creating a new environment at work with very strong leadership support and very strong benefits plan design changes, from high deductible plans to self-insurance to outcomes-based incentives to provide insurance premium discounts for those that engage or higher prices for those who don't. They reach out to spouses and significant others. They just do this very differently, and there's very few employers who get to this level. Now, I mentioned earlier, right now we have the C. Everett Koop Award that we're evaluating. This is, I think we have 11 applicants this year. I've been part of the board for about 15 years now. We've been looking at the best of the best of the best of the wellness and worksite health productivity management programs out there. From a healthcare cost perspective, we can even plot the Koop Award people and everybody else. Do nothing, healthcare costs go up, and I got some charts to show you that. We started off with a few of them. Traditional program, well, we bend the trend a little bit. Comprehensive, maybe a little more. That's the champion company, and that's where we get this idea of zero trend. And you're saying, oh, zero trend, that's poppycock. That's not true. I got 11 applications on my desk right now. These companies have done an amazing job of changing the trend of high cost. And wellness is a big piece of their approach. It's not the only piece on their approach, but it's a big piece. And here are some of the other ones that have done this. I mean, Berkshire Health Systems and USAA and Houston Independent School District. These are some of the groups that have done this exceptionally well. So where are we at? Well, the drivers of cost aren't going anywhere. I see little coming out of Congress to really change any of this. Very little. So you have your toolbox. You can stop offering benefits, you can shift the cost, you can self-insure, negotiate rates, you can decide which of these you want to do, and each of them, for the most part, plugs in somewhere and does have an effect to a degree, some more than others. So let's go back and say, why are we really here? Well, you got to explore all of the strategies to contain medical costs, not just wellness. Wellness, in my opinion, and based on the evidence, is the strongest. When you take wellness and you couple it with a high deductible plan and self-funding, it's what I call the 1-2 punch. And these champion companies show us that health can be improved and medical costs can be contained when we work on this strategy together. I wish we would have some options that would make it cheaper. I wish Congress would intervene or industry would get together and redesign. I don't see any of that happening for quite a while, to be honest with you. So what we've done is we have taken that information that I've shared with you today, and we've created an infographic. Here's the WellSteps page. Here's where this webinar is posted, the free webinars page. You just click on the webinars link. The webinars link has today's slides and this great infographic right here, where we've taken these strategies and put them in a really fun, easy to read infographic, healthcare cost control strategies, the good, the bad, and the ugly, where we talk about cost shifting, changing carriers, self-insuring, and what do we know about those pieces, high deductible plans and where they're at, something you can pass along, something you can use to remember and use very easily as you talk about this information. The references for today's discussion are all posted on the links on this page. You want to know where it all comes from? And most excitingly, August 28th. July, we take the month off, but Dr. David Honeycutt, after 30 years, is leaving WELCOA as the president. Nobody has done more to contribute to the growth and success of worksite wellness programs than Dr. David Honeycutt. He's retiring, and David has graciously agreed to do a webinar for us and to talk about the things he's learned in the last 30 years about how to do this. When I talk to David, and I consider David a good friend and we visit often, I know few people who have probably influenced public health, especially employers' health, than anybody than David. Millions upon millions of lives are touched with his materials, with his presentations, with his newsletters, with his books, materials. He has done more than just about anybody I can think of to really change the dynamic of where we're at. So we want to encourage all of you to join us in August for that. And with that, Troy, Ryan, I know we've got some Q&A to do. We've got about 8 more minutes.
We do. We have lots of questions, Steve. I have a comment from somebody in Canada. MJ in Canada says employers, is a mild correction, they do offer healthcare for some services that are not free, such as physiotherapy, massage therapy, and dental work. He wanted me to point that out.
And that's true. That's true everywhere in the world.
Sure.
But they all have a public option for everybody.
Absolutely. John had a great cost. I think you can answer this really quickly. It's actually back up on slide 70. This is a slide you shared a couple of places. You said of the cost drivers you listed on the left, off the top of your head, which on that list impacts costs the most on a percentage basis?
There's 2 that I am very comfortable. Well, I'm not going to say that. You really want to knock the cost out of the park? Stop offering the benefit. That's it. I mean, it doesn't. You have to decide if that's something you want to do, because that's pretty draconian. But WellSteps never even went down that road. We're new enough to not have to go down that road. But if you want to offer benefits, then you've got to go something like self-funding and high deductibles in the meantime. But stopping benefits, Trader Joe's, Home Depot, Starbucks, the list is going to grow. The list grows larger every day. That's
Okay.
an option. I threw it out there.
Awesome. Thank you. Elizabeth asked, just wanted to know why self-care didn't appear on the list on the right. She asked, what about educating employees to be smart healthcare consumers as one of the strategies?
That's one of the ones that I mentioned that didn't get on the list. There are others that are on that list. The whole business of of demand management is certainly a strategy that people can use. When we stack it up against some of these other ones, it just didn't there. And I probably should have included it today, but I wanted to, for lack of time, to get there. But yeah, I think having a 24/7 nurse hotline, I think self-help guides, self-help books. We have a self-help campaign at WellSteps. They're certainly an important piece to this equation, and I don't want to. I suppose I should have included it, but yes, you are correct. It's one more to put on that strategy list.
Okay.
Unless you're not going to insure your people anymore, and then it's gone.
So when you talked about high deductible health plans, you really stepped on a nerve. There were many comments that came flooding in when you mentioned that. Nancy had a couple of really good ones. She wanted to know just quickly, what about low wage earners who often have low health literacy? Won't high deductibles mean that they have to stay away from care until they're sick? Those will become the high cost employees. So just a brief thought about that.
Yes, there are 3 really good studies that have been published asking that question in several ways. People who have high deductible plans versus those who don't. They do go to the emergency room less if they're high deductible plan. But when they look at health outcomes, is this impacting their health? There is so far no data that has been published in the literature that shows that they're using the services inappropriately. However, I tend to agree with you. The way to set it up is to make sure that all your preventative services are free, and by Affordable Care Act, they have to be by law. But as an employer, you can provide enough money to them through an HSA or an HRA to technically build up a case where they have their deductible in place. So it's almost as if they don't have a deductible because the employer has provided a big portion of that. That's what Home Depot does. That's what Trader Joe's do. They provide some money to fund part of that high deductible to take some of that burden away. And I agree, and I have worried about that.
Thank you, Steve. Related to that is there's a reference to, Nancy refers to a reference to a study by the RAND Corporation, who found that co-pays reduce preventive and chronic care, but not acute care. And I believe that was pre-Affordable Care Act, but you might want to just address that.
That is pre-Affordable Care Act, because that's illegal now.
Mm-hmm. Okay, that was an easy answer to a pretty provocative question.
I'm just really happy that there are some really good pieces in the Affordable Care Act, and this prevention piece, in my opinion, is huge. There is no reason for any person in the U.S. to not get preventative services because they are 100% covered. Now, that's from an employee perspective. As an employer, self-funding, I got to pay for that. You pay for those services if you're self-funded. But I think there's sufficient data to support the prevention of those diseases going forward, especially the early detection of those conditions going forward. You want disease management? Get those diseases early.
Yeah, there were several other questions about the Affordable Care Act. So I'm just gonna, if you're one of the people who ask about that, I go to the webinars page on off the WellSteps homepage and scroll down to the archives. There were a couple of really good webinars Steve and I did in late 2013 about the Affordable Care Act. I'm just going to refer you to those. Here's a great question from John, Steve. He says, are self-insured employers more apt to support wellness initiatives? And if so, what type of initiatives? It's a really broad question. Thoughts on that?
This is an important one. If I'm doing wellness and I'm doing all my other cost containment strategies, they're going to have a larger impact on me if I'm self-insured because I'm essentially saving my own money. If I'm fully insured and I'm paying premiums to an insurance company, if we save all this money in healthcare utilization, it's not really saving my money because I'm not paying for it. The insurance company's paying for it. So yes, the groups that benefit the most from all of these strategies, especially wellness, are those who are self-insured. Now, which wellness components do you want to implement as part of a self-insured plan? Well, we got lots of webinars and lots of content about that. And there's a variety of ways to do that, but it's got to have reach. It's got to touch everybody and have impact. It's something that actually works. So that's a topic for another discussion, but I send you to the webinars to see some of our topics on that one.
We have time for, we have way more questions than we're going to have time to ask. So my apologies in advance to those of you who've asked very good questions we're not going to have time to get to. We have made time for one more question. This is from Elizabeth Haney. You might have already addressed part of this, Steve. Any tips for how to jump from a comprehensive to a champion company? She says, we have elements of both, but we're not quite at the champion level and we want to get there.
We evaluated a lot of our WellSteps clients because we have some that just knock this out of the park and some that struggle. And we've decided what is it that, how do we get them from good to better to best? And we've identified those strategies which we know are correlated with the best results. So the champion companies have a very strong benefits-based incentive plan, whether that's something tied to their premium, something tied to a copay or a deductible or a separate insurance plan. When you do healthy things and you participate in our wellness activity, you qualify for our healthy lifestyles plan. If you don't, you don't qualify for it. You can't get it, or your premiums are higher. It could be a paid day off. It's something tied to benefits, has a lot more staying power and gets a lot more participation in those programs. Leadership support, as everybody knows, is huge. That means there's a committee in place. The committee helps design the programs. The committee takes ownership in what the programs are going to be offered at the worksite. And it's trickled out to all the worksites, spouses, significant others, those with disabilities or those who have difficulty accessing. Those are those critical strategy pieces that we see that the champion companies have. And they're using most of the tools in the toolbox.
Again, there are many other great questions, some of which are the fantastic questions we otherwise would have asked. I want to thank those of you who have attended and those of you who have participated by asking questions. Once again, this next webinar in August, we'll be earth-shattering, groundbreaking, will probably be the best webinar that we've ever done. I'm just going to go out on a limb. David Honeycutt is fantastic. He's got lots of insight. He's done so much in the last 30 years to advance our field. We're very excited that we were able to get David Honeycutt on his farewell tour. This is like the kickoff performance in Yankee Stadium. This is huge. Please register right now. You can do that right now on the WellSteps web page. The seats are going to be limited. They're going to go fast. Thank you again for your participation. We hope that you have a fantastic weekend and enjoy it, and we'll see you again. Bye-bye.